Perspective on Florida Gateway College Television is sponsored by Potash Corp of White Springs. Potash Corp, helping nature provide.
Hello everyone and welcome to Perspective. This is a public affairs presentation of Florida Gateway College. My name is Mike McKee and my guest on the program is Dr. Tracy Chapman. He is a pediatric hospitalist at Shands Lakeshore Hospital. We're going to talk about childbirth, which is something we've never done on this program before. We'll do that when we come back.
Being a registered nurse is a rewarding job. But if your career goals have you looking for more, Florida Gateway College can show you the way.
As a nurse, I love to help people.
But I wanted to go further.
With our Bachelor of Science nursing degree, RNs have the opportunity to increase their career options and income earning potential.
Now I've got more choices, and the extra money isn't bad.
Start your journey today at Florida Gateway College.
Welcome back to Perspective here on Florida Gateway College Television. Dr. Tracy Chapman is a pediatric hospitalist at Shands Lakeshore Hospital. Welcome to the program.
Thank you so much.
I think you may be the first pediatrician that we've had on the program, but that's kind of cool. Let's talk a little bit about what your job is. Maybe when I first came on the air, I said pediatric hospitalist. A lot of people's eyes glaze over. What is your job?
So, pediatric hospitalist takes the place of the pediatrician in the hospital. So, I do not have a clinic of my own. I work exclusively for the hospital, and when I'm working, I only work in the hospital. So, any pediatric patient that comes to the hospital generally will get admitted to my care, and then I will keep them as long as they need to be kept in the hospital. And after they are discharged, then they will go back to their general outpatient pediatrician's care. Now, because Shands Lakeshore is a smaller community hospital, we don't get a whole lot of kids that need to be admitted, or kids that need to be admitted that can just be done without any specialty care, because we don't have access to any specialty care for pediatrics here. So I'd say about 90% of what I do is deal with the newborn babies in the hospital.
But you do, if a kid comes to the emergency room, that you're in charge. What is that age? What is considered pediatric?
0 to 18.
18. So
Yep.
18 years old. Anyone that do you take care of like breaks? Was that where you come in, or is that an orthopedic specialist?
The orthopedic specialist will generally take care of any sort of a broken bone. Usually those are just set in the emergency room and they usually go home. If they do need surgery, then every once in a while they will admit to my service and then consult. Essentially, I'll consult them to do the surgery, and then they will go home after the surgery is done if it's that bad a break that it needs to be surgically fixed.
Now, do you follow the patient? Should they have to go to a specialty down in Gainesville where the orthopedic surgery may be a little too complicated to perform here in Lake City?
No.
You're
If they
typically
go outside of the hospital system, then I don't follow them at all. Yep, and outside of our hospital.
So if somebody presents at the emergency room and it's a child, maybe a 2-year-old, that's had a high fever for a long period of time, will you be called in on that type of thing?
It depends on what the emergency physician at the time thinks. If they have a question, they'll call me and I'll come in and see the kid and give them my opinion. If they think the kid needs to be admitted, they'll call me, I'll come in and see the kid, and then end up admitting the kid or saying, no, I think this kid is too sick for our hospital, might need specialty care, you need to transfer the kid elsewhere.
So do the ER docs like that? I mean, that there's somebody that's on staff? I mean, you're there all the time, basically.
I think they very much like that, yeah. I mean, because they see a good deal of kids actually at the hospital, but it's not primarily what they see, and it's not what they're used to. They're used to.
Well, and I wanted to, we talked before we came on the air, there are some challenges that you face that no other doctor faces. We had a podiatrist on the program that was talking about communicating with their patients to find out what's going on, and the patient says, yes, it hurts when you touch here. Well, with a child, all they know a lot of times is they don't feel good. Mm-hmm. And so what challenges, I mean, obviously communication.
Well, it depends on the age. I mean, obviously, anybody older than 7 or 8 years old can usually tell you with a pretty good idea of what's going on. But the younger kids, I always felt was actually they were more honest with their illness, even though they can't exactly tell you what it is. And so it's a very, in-depth discussion with the family, with the parents primarily, about what they've been doing, how they've been acting. And a lot of the treatment then is symptomatic care when you're dealing with kids that are too young to talk to you. If they're not drinking, you give them IV fluid so they don't have to drink. If they have a fever and they look miserable, you give them Tylenol to take the fever away. And then it's just kind of, you see how they do as they go along, as they fight off infection themselves.
Now, when you say that the child is honest, they've got no reason to tell you a story. Do you sometimes have a parent that says, well, no, that's not the case, and then you find the child is, that's not really true, Junior. You did eat all that.
Yeah, you definitely get parents who argue with you about certain things, but in the end, generally the children will tell you how they're feeling overall, and they're pretty honest about it. And that's part of the reason why I like working with newborns too, is because you lose the parental concern aspect about a lot of things because they're so overjoyed at having the newborn around, that you don't get that kind of argument about, no, my kid really is sick, and you say, no, your kid's not that sick, kind of thing.
Yeah, and there are overprotective moms out there and dads that say there's maybe almost hypochondriac about, my child has got this and this, and you've got to overcome a lot of that.
Yeah, and there are psychological diseases that go along with parents where they can't get the medications or the attention for themselves, so they impress it on their children, and it's a very difficult situation. Again, don't get a lot of that in a smaller hospital, but certainly in bigger hospitals where I came from, we saw that.
Dr. Chapman, I wanted to ask, we're all going through flu seasons. It seems like the flu season is any time now. It's not just during flu season. You can get the flu anytime. You see the kids when they come in and they have to be hospitalized.
Correct.
Have you seen is there a lot of that going on? Are a lot of kids just not able to fight off whatever's out there?
Well, anytime you're dealing with a viral illness like the flu, there's no treatment for it. So what causes them to be hospitalized are serious symptoms. Symptoms of pneumonia or meningitis are the biggest two. But other than that, it's usually just dehydration that leads them in the hospital with me. And so these are kids that just feel so miserable, they won't eat anything, they won't drink anything, and they end up just staying in the hospital for a couple of days for IV fluids, or maybe just overnight. There has been quite a bit of that. I think most of them are getting sent home from the ER. Most of them are. I was hospitalizing some infants, 6 months old, early in the season, October, November. Haven't seen quite as many recently, although there was a huge stomach bug that just came around last week.
Now, I'm going to ask you a question. You don't have to answer this, but do a lot of parents want you to give them something? Because you mentioned viral normally has to take its course, and the body has to fight that. Being married to a pharmacist, I kind of know that antibiotics don't work. But you see a lot of parents that say, you need to give me something?
Yes. You see that a lot of times if you're in your clinic, my child is sick, I need to give it something to make it feel better, and it's a lot of education that you have to do, that most illnesses that children get don't need any sort of treatment for it, and it's only when it gets worse and gets bad, that they do need to get treatment. But you do get into that discussion a lot of times with parents.
What is, and I'm getting some free advice from you. You don't even know I'm getting this free advice. What do you typically do? Is it rest? You know, you hear the old wives' tale, and maybe it's the way it is, but rest and plenty of fluids is what I've always heard about treating those symptoms.
Plenty of fluids is probably the only absolute that you need to do. Rest, whether or not it actually makes a difference, I don't think it does for kids. You want kids to be acting as normally as possible. And so if they want to play, if they're up for playing, then you let them play. If they're febrile and want to lay around sleeping, you know, just laying around, you treat them as if you would yourself. If they have a fever, you give them Tylenol. If they look miserable, if they look like they're in pain, they can't tell us, like you said earlier, that, you know, their whole body hurts. And when you get the flu, your whole body hurts.
Aches and pains.
And they don't have the capability usually, you know, in 2-3-year-olds to ask us that. So you treat them as if they would have that pain. Give them a little bit of Tylenol, give them a little bit of ibuprofen, and it can usually make a world of difference in the way they act and the way they feel. But overall, it's really the hydration, because a dehydrated child compounds how bad they feel, and they feel infinitely worse, and it's usually what ends them in the hospital.
Lakeshore Hospital has been birthing children for years and years and years. What's changed about childbirth in the 2015s? I mean, you're a hospitalist and you deal with that quite a bit. Mm-hmm. Talk about the difference between the OBGYN, the pediatrician, and the pediatric hospitalist. There's 3 specialties that we're talking about. You're the one in the middle.
Yeah, well, the obstetricians follow the mothers and throughout pregnancy and take care of any fetal problems at that time. Also make sure that the mother is healthy, that the pregnancy is healthy.
So, I mean, they're there to go through the regular visits. How you doing? And I don't know what the time frames.
Ensuring that the baby's growing properly, making sure that everything's okay with the mother, because there are lots of pregnancy-related issues that happen.
Could be diabetes.
Pregnancy diabetes, hypertension of pregnancy, that kind of stuff. And so they're ensuring that that the mother is healthy and consequently the baby is healthy throughout the entire
that's an important part of this. I know there are some folks that don't see a doctor during pregnancy. They just for whether it's a money thing or whether they just don't know, and that's where you run into some problems.
Yeah, and it's always a concern for us whenever we get a mother that hasn't had any prenatal care and we don't have any prenatal labs on. There's a reason that we screen all these babies, because, you know, the more you know about something, the better you can prepare for it when they're born, and the better you can act on it when they're born. You know, a random prenatal lab that is missing could make the world of difference for a baby.
So what happens to you now? You've got someone that's going into labor. They don't have a primary care OBGYN. You're kind of flying blind, right? I mean, what are some things you look for now that the birth is about to happen?
Well, the biggest one is really infection. All mothers at 36 weeks generally get screened for something called Group B strep. It's a common bacteria that lives in the vaginal area, lives in the rectal area, and so we check all mothers at 36 weeks for that. Babies that are born to a mother that has a GBS positive status are a little bit more prone to getting infections when they're born. Sometimes, depending on how concerned you are about it, you can do screening blood work on the baby when it's born, which you never want to, you know, inconvenience babies if at all possible, and so getting a little bit of a blood poke is sometimes necessary. If the baby acts sick in any way, vital signs are unstable, it's having trouble keeping its temperature up, then you end up treating the baby with antibiotics before you even really determine whether or not the baby's sick, which is, again, scary and frightening for the families. If we don't know the GBS status, they try to give antibiotics during labor. to lessen the likelihood that the baby's going to have any problem with it. But again, if it's a very quick delivery, then you can't get the antibiotics in an appropriate time frame before the baby's born. You still have to worry about it. So that's probably the biggest thing you worry about is infection generally from the GBS status. Other things you're worried about, again, like prenatal labs, you generally check for things like hepatitis B, which hepatitis B is something that can cause significant trouble for newborn babies in their life if they're not treated appropriately. And the treatment for hepatitis B is giving them the vaccine and an immunoglobulin in the first 12 hours of life. And so you have a 12-hour window after the baby is born to treat this baby appropriately if you don't know if the mother is positive for
Now,
it.
you talk about hepatitis B, you're talking about lifelong problems, correct? That could end in
Yes.
a cancer at some point.
Liver failure,
Yeah.
significant problems.
Let's talk about premature. I know that the March of Dimes has done this show twice a year for the last, I think, at least 15 years. And we always have a story on our program about, and we bring a family in who's had a premature birth. And we talk about, surfactant, and we talk about the stuff that has happened because of the March of Dimes research. Do you get many premature births at Lakeshore? And I'm going to ask you this because you probably don't know if a woman presents and she's in labor and it's early. I mean, they pretty much know that. They probably tell you that, and then what happens?
So
It's probably a little scary.
we get a decent number, I think, of premature babies. We don't keep them. So any baby that's before 35-week gestational age will not stay in our hospital, okay, regardless of how it's doing after birth.
You send them to the NICU down at Shands in Gainesville.
Generally at Shands in Gainesville, yep.
Now, but they can be birthed here.
Yes.
But I guess what your deal is, you try to get them to Gainesville to have the baby in Gainesville.
Yes, they are much more able to. They're much more used to it down in Gainesville. They have a NICU down there, so they have neonatologists. They have fellows studying in their neonatology program. Much more experienced nurses for that sort of a delivery. But with that being said, if a mother comes in labor, premature labor at 30 weeks gestational age, we are not going to be able to transfer the baby or transfer the mother in time to have it be delivered down there. And so what we try to do is appropriate immediate resuscitation and stabilization of the baby until they come and pick the baby up.
Now, I guess it depends on the case. Do they fly them to Gainesville, or is it?
It depends on how stable the baby. A 33, 34-weeker that is pretty stable and has been doing well, they might take the ambulance up, but generally they will take the helicopter up. And they're fantastic. They're very used to it, and as soon as they get here, they generally, stabilize the baby as quickly as possible. It's generally stable when they get there, because it takes them an hour and a half, but they ensure that it's stable for transport back. They bring the baby to the room, to the parents, to talk to the family, to make sure that they understand everything that's going on. And I will have talked to the family too beforehand about letting them know that the baby was going to be transferred. The unfortunate aspect is the mother doesn't get transferred when that happens, and so the mother has to stay until she's discharged from the hospital while the baby gets sent down to the NICU.
So there's a disconnect there for a little bit, which is not always a good thing with a newborn, especially with the first newborn.
Correct. And it's very stressful out for families.
Well, I can imagine. Our society is not a perfect society, and a lot of sometimes pregnancies get complicated by drug use. And that's another thing you have to look. Are there a lot of premature babies born that parents are addicted?
Well, it doesn't even have to be a premature baby. A full-term baby can be born addicted to anything. And the things that you see symptoms for, the most common and probably the scariest one is methadone. So the mother is in a methadone clinic for
trying to kick it.
Yeah, but they can't really stop that during pregnancy. It's not safe for them to stop that during pregnancy. And oftentimes the methadone dose goes up with pregnancy because you have to give the mother more to alleviate their symptoms. And so some of that gets passed into the baby. And when the baby is born, then it's completely cut off. Now, breastfeeding can actually alleviate some of that because the baby still can get some methadone through the breast milk if mother decides to breastfeed, which can alleviate a lot of the symptoms.
Well, and so the baby's under distress because they've been pulled off a medication that's. Yeah.
So generally in the first 24 hours the babies do okay because they still have whatever's left over, but then after that first 24 hours then they can start to withdraw and they can start to be jittery, they can start to have feeding trouble, they can start to have diarrhea, they can show all sorts of different signs. If that's the case, we generally send them down to Shands for treatment, and the treatment usually is oral morphine for them.
Wow. It's a sad situation, but I mean, you've got to be on the lookout for all of these things, and that's what a hospitalist does in a pediatric situation. I wanted to talk about, you were mentioning C-sections. They do that at Shands. Is it common, or at what point do you determine whether, and I know the answer to this, but our viewers may not, how do you determine whether a C-section is appropriate for a birth?
Well, C-sections are appropriate for a number of different reasons now. I mean, it used to be, I think it was back in the 90s, where they would just decide to do a C-section. That is no longer the case. There has to be a clear indication for a C-section. Most common indication we see is that they had a C-section before. There are risks to having a vaginal birth after a C-section, and so most people who have had a C-section before will just have a repeat C-section. And those are scheduled times, the baby is full term, you expect very little problems with those, although any C-section itself will have a little bit of risk to the baby. It's not the natural process, and so they can have problems just with a normal, routine, scheduled C-section. The other most common causes, anytime there's a significant issue concerning the baby. So all babies are on monitors throughout the entirety of the labor process, and if the baby starts showing significant distress and is not anywhere close to being born, you have to get the baby out for the safety of the baby, for the safety of the mother sometimes, as quickly as possible. So that's probably the second most common. Anytime there's a arrest of labor, so if labor just doesn't seem to be progressing very often,
well, and that's when you're like 36 hours of labor, then
right.
Mama wants it more than anybody else.
Right. And that oftentimes is very stressful for the baby. Labor is a stressful process for the baby itself, so for it to be in labor for that long can cause problems. And then the last one is really presentation. So if the baby is not going head down, which is what it's supposed to do, if it's got butt first, usually that has to be a C-section. And so you just have to alleviate that problem.
Dr. Chapman, I appreciate you and your knowledge of pediatrics, and being a pediatric hospitalist I think is a positive for Shands at Lakeshore Hospital. Thank you for being on the program.
You're welcome.
And thank you for watching Perspective. Until next time, I'm Mike McKee. So long.